Good afternoon, everyone. This is Faith Runs, Director of Statewide Benefits. It is 1:01 p.m. and it looks like we just obtained quorum for this afternoon's SEBC Health Policy and Financial Subcommittee meeting. So I think we can go ahead and get started. Just a quick reminder to those participating, this is a public meeting. It is being recorded. The virtual recording will be available on the SEBC webpage later this week for viewing for those who were not able to attend today. So with that said, Carol, would you mind just doing a quick roll call of subcommittee members present?
Sure, absolutely. So here in person, we do have Director Faith Brents, and logged in virtually, I have Stuart Snyder, Ashley Tucker, Bert Scaletti, David Benz, Bill Oberly, and I just saw Courtney Stewart pop on.
Great. Thanks, Carol. In addition to Carol and myself here in the Statewide Benefits Office, we have Leanne Hinkle, Deputy Director, and Stephanie Hardis, SEBC and Subcommittee Manager. So I think we can go ahead and move to the first item on today's agenda, which is approval of the August 19th combined Financial and Health Policy and Planning Subcommittee meeting minutes. These were included in the materials packets sent to subcommittee members last week, and it is also displayed on the virtual platform. So I'd ask you to take a moment to review these. We'll certainly entertain a motion to approve these when you are ready.
This is Courtney. I'll make a motion to approve.
Courtney?
This is Bert. I'll second.
Thank you. And for those in favor, if you could please respond by saying aye.
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 Do we have any members not voting today? Or abstaining? Going to abstain myself as I was not present for the August meeting. Any members opposed to approval of minutes? All right, hearing none, the minutes are approved. Thank you. Just real quickly with regards to director's report, we did meet separately with a financial subcommittee this morning to review the latest financial reporting, including the August fund reporting. That information as well will be discussed with the SEBC at their meeting, which is scheduled for next Monday, the 23rd at 2 p.m. We reviewed the August fund reporting updates on the FY25 budget. And then there were also, as a follow-up from recent meetings with both the combined subcommittee and the SEBC, there was discussion on a couple of different scenarios with regards to rating the three populations in the group health insurance plan combined as well as separately. And then Brian Stitzel with Willis Towers Watson also walked us through a scenario where contemplating the retirees combined, so both non-Medicare and Medicare. Again, we will review those with the SEBC as well at next Monday's meeting. Brian also walked the subcommittee members through a refresher and some modeling on potential changes that could be considered by the SEBC with regards to the cost sharing and actuarial values of the non-Medicare plans, a couple of different scenarios and what that would look like in terms of impacts to both the employees and non-Medicare retirees as well as the state in those various scenarios. So similarly, we'll have some discussion those various modelings at next Monday's meeting. Additionally, for the SEBC meeting on the 23rd, the committee does have several action items on that agenda. Approval of the fiscal year 25 budget and approval of scopes of work for two separate RFPs, one being the life insurance request for proposal, and the second being the request for proposal for the medical and prescription claims and administration audit services. So again, those 3 action items for next week, and we'll have some discussion as well with the committee specific to item number 4 on today's agenda with the Policy and Planning Subcommittee. Just want to make one other call out specific to some public comment at this morning's Financial Subcommittee meeting with regards to the Medicare contract, which was awarded through a request for proposal by the SEBC to Highmark, Delaware earlier this year. That's for administration, continued administration, that is the special Medicare supplement plan for Medicare retirees effective January 1st of 2025. That contract is still being negotiated between DHR and Highmark. We're expecting that to be completed by October 1st. Along with completion of the special medical plan document so that that can be published and available on the website to coincide with materials that state of Delaware Medicare retirees will be receiving in advance of their open enrollment period, which is scheduled for October 14th through the 25th. So that those updates were provided to the SEBC as well at the August SEBC meeting. So any questions from subcommittee members before we dive further into today's agenda? Okay, hearing none, I think we're going to pivot over to a discussion on House Resolution 32 and some updates on the current group health insurance plan. Diabetes programs and services. Stephanie's going to take us through this discussion, and I just want to thank her in advance, her and her team, for their work specifically on outlining the programs and services that are currently in place. I think it's been a really great exercise for us to just reorient ourselves with what's available as we start to dive into the work associated with House Resolution 32, which she's also going to walk us through. So Stephanie, thank you.
Sure, thank you. Good afternoon, everyone. Stephanie Hardis, SEBC and Subcommittee Manager. So as Faye said, I'm going to be walking us through House Resolution 32, as well as providing a brief summary of the programs and resources that the SBO and state offer to members and employees related to diabetes management and prevention, which will tie to this resolution. So next slide. All right, so to start us off, House Resolution 32 was introduced and passed by the House on June 27th of this year. It urges the State Employee Benefits Committee to collaborate with a health system partner, as well as an external technology partner, to deliver focused and targeted care protocols to a measurable cohort of GHIP plan participants, primarily to proactively address the growing problem of diabetes and metabolic syndrome in our population. And I apologize, I should have included this in the presentation, but just to address what exactly metabolic syndrome is. It's a group of 5 conditions that can lead to heart disease, diabetes, stroke, and other serious health problems. So metabolic syndrome is diagnosed when someone has 3 or more of the following risk factors. So if they have high blood sugar, low levels of HDL cholesterol, which is the good cholesterol, high levels of triglycerides in the blood, large waist circumference, and high blood pressure. So if someone has 3 or more of those risk factors, they are diagnosed with metabolic syndrome, which this resolution is looking to address as well. So the overall goals of this resolution are really to improve the health of our employees and plan members, which would result in better health outcomes, improved quality of life, decrease in missed work days due to complications from diabetes and metabolic syndrome, and a potential to decrease plan costs both for participants and the state. So we at the SBO have been working internally on a strategy to best address the request of this resolution. So we've actually been meeting with some of the state representatives who sponsor this resolution, as well as clinicians within our health system, a population health specialist, even Dr. Nancy Fan, the chair of the Primary Care Reform Collaborative, to really develop a holistic strategy and framework to make sure that we're really working in this resolution in a way that will be beneficial to our employees. We did determine pretty early on that before we dive into the process of developing and piloting a new program, we wanted to really evaluate the programs and resources we currently offer to see the level of effectiveness and also improvement opportunities to really help dive into the problem and development of what we're seeing in our population. So we released a report last month detailing our current diabetes and metabolic syndrome programs, as well as the other services and resources that we offer. And this report contains some really good details and information on our participation in these programs, as well as metrics and outcomes when available. So I will review those programs and outcomes on a high level today, but the report has been shared with the subcommittee members as well as the SEBC, and it is publicly available on our website. So definitely encourage you all to take a look at that as well. Next slide. All right, so starting specifically with the Highmark non-Medicare programs, we have two programs with the company Livongo by Telehealth. So the first is a diabetes management program, which is for those who have type 1 or type 2 diabetes. And the second is a diabetes prevention program for those who are pre-diabetic, have metabolic syndrome, or are otherwise at risk for developing type 2 diabetes. So starting with the first program, the diabetes management program, this provides access to certified diabetes care and education specialists with the goal of helping with diabetes management. They also have expert health coaches who are available 24/7 for member support, and any members enrolled in this program receive a free glucose monitor as well as test strips. And just some high-level outcome information. Again, there's a full breakdown of this in a larger report. We currently have just over 1,000 members actively enrolled and participating in this program. And for members who have been enrolled for at least 6 months, we're seeing those share of members with controlled diabetes, which is what we want to see, which would be defined as a hemoglobin A1C of less than 7%. There's a pretty good increase. So at baseline, it's about 46% of all enrollees are in that controlled category. And then after 6 months, we see that increase to 73%, which is really great. The share of members kind of on the other side that have a hemoglobin A1C of higher than 8, we see that decrease from starting off at baseline 28% to after 6 months being just under 12%. So we're seeing that members who enroll in this program and after 6 months seeing some pretty decent health outcomes associated with the health coaching that they're receiving. The second program, the diabetes prevention program through Livongo, includes expert-led coaching sessions for nutrition, behavior change, exercise, as well as access to an online community with peer support. Members can use an online app and web dashboard for education on food and nutrition. They can track their weight and activity, and they can also text and email their personalized coach directly. So this program also has some really great outcomes, but unfortunately participation is very low. In the past year, we only had 18 members who enrolled in this program. And though out of those 18, 13 of them, so 72%, attained at least a 5% total body weight loss. And 8 out of the 18, so about 44%, attained at least a 9% weight loss. So seeing some decent outcomes for those who are enrolled, but again, we're working with Highmark to better promote this program to eligible members and get more people involved. Next slide. So additionally, with the Highmark non-Medicare plans, we offer the CCMU program, which is the Custom Care Management Unit program. This offering is not specific to diabetes or metabolic syndrome alone, but it does offer health coaches to help members get support they need for managing their diabetes, if they have the goals or necessity to lose weight, healthier eating, quitting smoking, managing stress. And really these care managers work directly with the providers and the members to get them more involved in their care and making sure that all needs of their care, whether it's medical or social, are being met. The Blue 65 discount program is offered to members and offers discounts on gym memberships, weight loss programs, massage therapy, and other services. As this is a discount program, it's actually administered directly through Highmark. So we, the statewide benefits office, don't get any reports or data specific to that program, as it does just offer discounts and there's nothing specific to enroll. Next slide. So focusing a little more on our Medicare retirees, Through the Medicare prescription plan Silver Scripts, we offer the Transform Diabetes Care Program, which provides a holistic way to manage diabetes and overall health for members. In addition to the general services such as glucose monitoring, this program uses health information that the users input themselves to provide personalized health coaching based on the needs of the individual. So users have access to trusted advice on nutrition, lifestyle habits, as well as they receive reminders about screenings, appointments, and any other services that they need. So this benefit is available at no cost to all AGWIP SilverScript members and helps address the gaps in care that they may be seeing. So just some quick high-level stats on this program. We have just over 29,000 SilverScript members, and over 7,000 of them, about 25%, were identified as being eligible for this program as they have a diagnosis of type 1 or type 2 diabetes. So of those 7,000 members, about 94% of them were identified as having a gap in care. So gaps in care can include things such as medication adherence, screenings for things, whether it's related to diabetes or other conditions, medication optimization, the management of comorbidities that they may have, and access to devices, just to name a few, so such as a glucose monitor or a blood pressure cuff if they need it. And in the last quarter, just about 2,000 of those gaps in care were closed, primarily being on medication adherence, screenings, and medication optimization. I did want to call out, this isn't on the slide, but Medicare does offer a diabetes prevention program as well. This program is not affiliated or administered by the state of Delaware. It's through Medicare directly. So members who are interested, who are a Medicare member and they do not have type 1 or type 2 diabetes, but are interested in a diabetes prevention program, they can actually go on the Medicare.gov website, search their location, and find programs near them and see if they qualify. So I wanted to provide that as an option as well. Next slide. All right, so moving on to the Aetna programs that we offer. Again, Aetna is our non-Medicare plan as well. So they also offer Transform Diabetes Care, but it looks a little bit different than what we offer for the SilverScript plan. So for Aetna members, this is a 12-month program that helps keep diabetes in check at, again, no extra cost to the member. It gives customized guidance based on each member's specific needs. So members can use the CVS Health Tracker app to monitor their glucose and blood pressure. They can track and share their readings with health coaches, learn more about their diabetes and how to maintain healthy lifestyles. There's even recipes and nutrition counseling to help members make meals that really align to whatever their specific needs are. Again, as I mentioned, they get personalized support from a certified diabetes care coach, as well as they also have nurses who are diabetes specialists within this program. So anyone who is an Aetna member and has either type 1 or type 2 diabetes is automatically enrolled in this program, which is actually about 7% of all Aetna members would be qualified. So the way that the program works, Aetna actually sends out welcome kits to those eligible members. In the past year, they sent out just over 2,000 kits, and about 90% of those members received additional outreach from Aetna about the program and just managing their A1C levels. All right, I see we have a hand raised. Bill? Hi, Mr. Oak.
Yeah, Bill Oberly. When I read through this over the weekend, the reference a 12-month program. What happens after the 12 months?
Sure, that's a great question. So if someone in this program still needs that managed care after 12 months, they would have the option to work with the Aetna One Advisor program, which is the care management program. We'll get into it a little bit later as well. That's offered to all Aetna members. They can reach out to Aetna One Advisor and get connected with a care manager. If they need a social worker for any particular, maybe social determinants of health issues, as well as nurses and other clinical staff, if they need more additional support than just the 12-month program.
Okay, thank you.
Absolutely. Great, thank you. Next slide. So as far as diabetes prevention for those Aetna members, we do offer the Solera program for this group. This program is designed to help members lose weight, adopt healthy habits, and reduce the risk of developing type 2 diabetes, again, through a very individualized and personalized program. This as well is a 1-year diabetes prevention program. That includes, it starts off with 16 weekly sessions. Once you're past that 16 weekly session point, you have monthly sessions with a lifestyle and nutrition coach, as well as there are small group support that you can join to work with others going through a similar journey. And members can choose to do this person. There are in-person locations that you can do through solutions such as Weight Watchers, or there's also virtual programs as well. Again, this diabetes prevention program is offered to Aetna members at no cost. And members who enroll and complete the first 4 weeks of the program, they actually get a free Fitbit, which is a fitness tracking device similar to a watch that you can wear on your wrist. In fiscal year 2024, we had 532 Aetna members enroll in this program. And a theme that you'll see actually throughout the full report, 80% of the enrollees identified as female, where 20% were male. The highest enrollment ages were between the ages of 50 to 59, and 30% of all enrollees achieved at least a 5% weight loss with this program. Next slide. And we'll touch on this quickly. So with Aetna, they also offer the Able2 behavioral health treatment program, as well as Aetna One Advisors we had mentioned earlier. So these again are free resources to help Aetna members manage their health. For Aetna One Advisor, they coordinate care between providers, PCP specialists, and help members meet their health goals and making sure that whatever needs may be not being addressed, whether it's just with a PCP visit, if there's some concerns with their labs, the Aetna One Advisor program will help members get connected to a clinician, to the nurse line, to make sure that they're getting the support that they need. The phone number actually for Aetna One Advisor is found on the back of all Aetna member ID cards. And they're a really great resource, like I said, even for social needs, if someone's having issues with transportation to an appointment, if they want to eat healthy, but maybe they live in a food desert or they don't have any access to nutritious food or having difficulty being able to purchase that, they can reach out to the Aetna One Advisor program for that immediate support. Okay, next slide. All right, so going into other GHIP programs and resources that we offer, the high market Aetna non-Medicare members are also eligible to participate in the YMCA's diabetes prevention program. So this provides a supportive environment where members can work in a small group setting. I believe they actually still do some virtual options as well, to learn how to adopt healthy habits to reduce their chances of developing type 2 diabetes. So as you can see on the screen, this program is actually based on the diabetes prevention program funded by the National Institutes of Health, as well as the SEBC. And this program is available not just, like I said, not just in person at the YMCA, they also have sites on community centers. They also do some work site interventions as well. And this again is a 1-year diabetes prevention program. There's 25 sessions that occur within this year, focusing on nutrition counseling. There is even some cooking classes occasionally with this. And if someone goes to the YMCA to participate in this program, a lot of the times you'll see the health coaches will take them over to the weights to teach them how to use certain machines, and make sure that they're exercising in a safe way that's beneficial to them. As an added membership that we offer through the YMCA of Delaware, participants of this program receive 4 free months of family membership at a YMCA in Delaware. So in fiscal year 2024, we had 145 members participate in this program. Again, the theme that I mentioned earlier, 83% of enrollees were female, 17% male. 20% of all enrollees achieved a 5% weight loss. And then additionally, 30% achieved a 9% weight loss. Just to call out, one of the issues that we see with this program is adherence. So I did state earlier that members get up to 4 free months of a YMCA membership. And something that we've noticed kind of in our data is that once those 4 months are up, we start to see some members not participating anymore, even though this is a 12-month program. So I think something that we can try to address to really get members to complete the full 12 months and get the full benefits of the DPP program. Next slide. Thank you. So additionally, other programs that we offer. So under the state of Delaware prescription plan administered by CVS Caremark, we have a diabetic medication and supply savings program where a member with diabetes can get supplies such as lancets, test strips, needles, and syringes provided at no cost when the prescription is filled at a participating pharmacy, or they can also fill it through the mail order CVS Caremark home delivery. Additionally, with our vision plan benefit, so the iMed State Vision Plan, anyone with diabetes who is on this plan, they receive additional eye care benefits. So for members with type 1 or type 2 diabetes, they can obtain a vision evaluation every 6 months, up to 2 times per benefit year, to better monitor for signs of eye-related diabetes complications like diabetic retinopathy, which can actually lead to blindness and is a pretty concerning issue that we've been seeing, not really just in our population, but nationwide, just those long-term eye-related impacts of uncontrolled diabetes. So a benefit that is quite underutilized, and that we really encourage any member who has diabetes and is on our state vision plan to take advantage of those additional screenings. Next slide. Thank you. Additionally, I know there's a lot in here, but we do also offer the Husk Wellness Program, which again, it's a gym discount membership program, but they also provide discounts for fitness equipment and technology. So say a member wants to buy a treadmill or weight set or even a Peloton. If you go through the Husk Wellness benefit that we offer, members can get those that equipment and technology for a reduced price and for a discount if you use this benefit. We also, outside of this benefit, offer a wide variety of gym discounts in all 3 counties. We have a quite lengthy list on our website that members can take a look at, including there's Snap Fitness, I know has a few of the locations, I believe LA Fitness, YMCA, and some smaller gyms throughout the state. So definitely something that we're going to continue offering. And like I said, it's available in all 3 counties. So the last benefit program that I just wanted to quickly call out is our Employee Assistance Program, which we currently have through CompSite Guidance Resources. So again, this is a free program for non-Medicare members that we have, which offers confidential emotional support from highly trained clinicians, online support. We have really great interactive digital tools and programs for mental health, so anxiety and mindfulness, but then also more in line with this presentation, fitness and nutrition, personal health. And again, we mentioned this before, but non-Medicare employee spouses and dependents get 5 free mental health sessions with this program. And outside of that, there's a lot of additional really great benefits with our Employee Assistance Program. You can get legal help within this program. There's financial counseling within this program. Just a really great place for employees to go for any additional resources. So everyone can benefit from our EAP. So always like to put that out there when we can as well. All right, so I believe, yeah, you have a hand raised, Mr. Overly.
Yeah, thank you. The other thing that I thought about as I went through these documents is how well the providers and we as the state market these programs. Quite honestly, and maybe I'm the only one on the subcommittee, there are programs available that I never heard of or knew about. So I'm just curious, from a marketing standpoint, do we need to do more, I guess is the question.
Yeah, absolutely. I think one of the difficulties with a lot of these programs is that it really depends what plan you're in for what you're able to utilize. So for example, if you're in an Aetna plan, you cannot use the Livongo resources. That's specifically for Highmark, and vice versa with the Solera Diabetes Prevention Program. Our TPAs, Highmark and Aetna, do promote these on occasion to our members. We do send out flyers and notices about these programs. Something that we've been working with more on our health plan TPAs is to try to get more directed communication to members who do qualify. But again, your point is completely well taken, and agreed that most members do not know all the benefits and resources that are offered to them. So something that we really wanted to, with this presentation and as well as the report and just conversations we've been having with the heads of state agencies to really try to better promote these programs. And additionally, just want to call out, in early 2025, we'll also be releasing scorecards for our state agencies as well as our schools, which really give the leadership of these agencies a chance to see what are the primary health conditions and concerns that their employees are experiencing, and can really use that opportunity to really showcase these programs and benefits that are offered. So completely agree, Mr. Overly. We definitely need to do a better job, I think, at making members aware of what their benefits are.
Yeah, and.
You know,
Go ahead, Tom.
no, go ahead.
I was just gonna comment, in the short term as well, we've had some internal discussions about, opportunities to more directly promote these programs through targeted emails to the active employee population. Obviously, that's an easy thing to do. For the retiree population, we now do a newsletter twice a year. So we're preparing the fall newsletter that will go out in mid-October. And we're actually going to draw some attention, particularly to the diabetes resources in that communication. And then we're talking as well, we're always planning ahead and thinking about next year's active and non-Medicare open enrollment, which I will share with this group. We plan to bring back on-site education sessions and opportunities for employees and non-Medicare retirees to come out and meet with the vendors, bring back the health fair type events that we had prior to the pandemic. But specific to the education sessions that we want to run simultaneously with those health fairs, we're having some internal discussions about using those education sessions as an opportunity to really focus on some of these programs that are tied to the chronic conditions that we're seeing in our population. So we're kind of excited about that because we think, we'll have a little bit of a captive audience and an opportunity to showcase some of the added benefits of their health plans that perhaps folks aren't, really aware of. So it's just a couple of other things that we're doing, but Bill, I didn't mean to cut you off.
No, that's fine. I mean, the one that prompted my interest was Husk Wellness. I quite honestly had never heard of it. And, perhaps that's on me, but, I just think, there's an attempt here to be proactive, and the more we promote it, the better off I think we're going to be, and the GHIP is going to be. That's all. So.
Yeah. Okay, Jacqueline, I think this is probably.
Oh, actually, Steph, this is Brad. I just had one question for you. That's okay. I was kind of comparing and contrasting the Highmark and the Aetna diabetes prevention programs. And it just struck me that there's, unless I'm reading the numbers wrong, that there's just a very different level of participation in the Aetna versus the Highmark program, even though Highmark has a larger share of our enrollees. So is there aspects of the Aetna program that could be transferred to the Highmark program? Or I'm just trying to understand kind of why one seems to be fairly decently subscribed and the other does not.
Yeah, thank you. That's a great question. So I will say with the third diabetes prevention program, the YMCA program, we do see the vast majority of those members being Highmark members. So that could be an additional reason why we're seeing lower utilization for the Livongo program. But as far as differences between the two, I think with the Solera program, getting that free Fitbit, that free exercise tracker, that's not something that's offered under the Highmark program, which definitely could be an additional incentive for Aetna members to be joining. But completely agree. I mean, the Livongo diabetes prevention program has shown a lot of really great success, but just such low utilization. Each health plan promotes their benefits differently. So potentially it could be more, Aetna's pushing more the Solera program as opposed to Highmark, but I don't have our communications information on those programs, but Faith, I'm not sure if there's anything you can add with that.
It's a really good observation, Bert, and I think where we were going with this was first starting with just trying to get a sense of how engagement's been and what impact the programs seem to have had on those that engage. But the intent here now is for us to take this information and go back and start to ask some of those very probing questions of the the folks that are behind these programs, so that we can really try to figure out what's that sweet spot that we can potentially offer members to really get them engaged. And then going back to House Resolution 32, I mean, I think part of the intent there is really for us to keep exploring some of the new technologies that are coming out in the marketplace and, different ways that we can get people to pull, to really feel like they're engaged and committed to some of these programs. Like we've got them here, but we're still really struggling with getting people to really get involved. So, this was the first step, but Stephanie and her team are really focused on this, and we're really hoping that over the next couple of months, we can continue to have discussions with this group and possibly elevate some recommendations to the SEBC around ways that we can hopefully increase engagement in these programs.
Great, thank you. Thank you very much.
Thank you. Just to wrap up and tie it back to the House Resolution 32. So of course, as it has been mentioned, we definitely have a long way to go to better promote these programs and manage these conditions. At the SBO, we're going to continue reaching out to those stakeholders we mentioned earlier. Even thinking actually the last SEBC meeting, the president and CEO of the Delaware Healthcare Association requested additional collaboration with the SEBC. This could be a great way to really bring that resolution in and better manage these conditions. So, of course, any program or pilot that we would potentially do that would really impact and address all aspects of these chronic conditions. We're still figuring out any potential funding component. Unfortunately, that's a really big item that we would have to look at. But at the end of the day, I mean, it's been mentioned, we have quite a few programs already that we think we can better promote and utilize. So thank you for the time today to get to go through that. As I mentioned, there's a full report that has a lot more outcome and metric statistics that I would recommend taking a look at to hopefully continue this conversation. I know we at the FBO were pretty excited and happy to see that this resolution was passed, and hope we can keep the interest and momentum going to make more sustainable changes. So that wraps up my presentation today. Is there any additional questions or even just any comments from subcommittee members related to our diabetes programs or thoughts on the resolution?
Stephanie, I just want to mention, for those that would visit the statewide benefits web pages and specifically go in through the employee or the non-Medicare pathway, there's already information on the diabetes programs and services. We are working currently on building that out similarly for the Medicare population, so we should have that up and running in the next couple of weeks.
Thank you.
Thanks, Stephanie. All right, I think that moves us on to another proposal that we want to bring forth for consideration today. We've had some recent conversations about some virtual health, telehealth program opportunities specifically for Aetna members, and the benefits office has also been in some discussions with Highmark about an opportunity to enhance the virtual health programs and services that are available to those members as well. So want to get into that a little bit with the subcommittee and hopefully get your thoughts and reactions today. I think it's Jacqueline with Willis Towers Watson Good Office for this.
Thanks, Faith. I'm actually going to turn it to my colleague, Michelle Gast, to take us through this topic.
Thanks, Jacqueline. Hi, hello, Michelle.
Hi, Faith. Good afternoon, everyone. So as Faith Lead mentioned, the subcommittees have already been given overviews and made decisions around the Aetna program. So now we're going to dive in a little deeper from the Highmark side to look at the enhancements that are available this year. So I'll move forward to the next slide. So this slide, we're going to focus primarily on some background information and also just give an overview of the options that are coming and what the next steps are. So as you can see, currently, the state of Delaware utilizes the Well 360 virtual health program for telemedicine. This is for our Highmark non-Medicare health plan. This currently includes urgent care and behavioral health services. And there is an admin fee, the per employee per month, and a per claim charge when the services is used. services are used by a member. As a part of the annual review this past year, the enhancements to this Well 360 program were proposed to the SBO. So those are primarily looking to see options for primary care, women's health, and dermatology. And they also utilize that same admin fee, so the per employee per month and the per claim charge, which will go into the services and those options on the next coming slides. One of the things we wanted to point out here is the main difference I'd say right now between what Aetna has and Highmark employees have available with the telemedicine services is that Aetna's program currently has dermatology and Highmark does not. And the enhancements here are showing that dermatology is one of those options. But then Highmark is also providing additional differentiators, which are the women's health and the primary care. So again, we'll go into the details on those, but I just wanted to highlight that as we dive into the details on the coming slides. And as a next step, the SBO will be looking to have the subcommittees give a recommendation on this for the SEBC. It's October 28th meeting. Any questions before we go into the details of those enhancements and the cost expected? You can go to the next slide, please. Perfect. Okay, so on this slide, you'll see that the admin fee, so this is the same admin fee that is currently in place for the Well 360 program. So that's the 0.65 per employee per month. And then the information that is below here is breaking up primary care, women's health, and dermatology and showing the per claim fee. And this is before member cost sharing unless it's otherwise noted. So for the primary care, that's $75. For women's health, it's broken up into the lactation for initial visit and follow-ups with the $115 and $69. And then the medical urgent care, which is the same as the urgent care costs currently outside of women's health that the Well 360 program has today, which is $64. And then for therapy at the master's level and doctorate level, there is $90 and $115. And then for dermatology, you'll see the $95. Similar to what you have heard, I'm sure, in the past, the telehealth options, of course, will allow for expanded access to care with more options to schedule, diagnosis, treatment, and prescription medications for a broad array of health issues, and faster access to care. One of the things we also wanted to just discuss is understanding if these enhancements needed to all be elected or if the state has the option to do one and maybe not two of the others. So we did reach out to Highmark on that, and our understanding right now is that they currently have done this in bundles, but that's not to say that if the state wanted to explore doing just one of them, say, for example, dermatology, as I mentioned earlier, is now available for Aetna, so you may want to make that available for Highmark members. That is something they can explore, but it's to date, they tend to do the bundles. But again, they were open to looking into that if that's something you wanted to explore. Any questions on this slide? Is that Bill?
Yeah, could you define for me, I mean, I generally have some sense of what it means, but women's health, that can encompass a lot of different things. Can you define for me what would be covered under this proposal as it relates to women's health?
So I think, at least from my understanding, the main differentiators are around these focuses here, so that the lactation appointments and the therapy kind of separate that. The medical urgent care, I think previously you may not necessarily have a physician or consultation with somebody that is focused on women's health. So having that specialty where now this opens that opportunity for those different appointment types specifically, as well as urgent care that has somebody that is focused in that area.
Okay, I'm not sure that answered my question. Just an additional question. The enhancement additional pricing would be 65 cents per employee per month.
The admin fee, yes.
Okay.
And Mr.
Which
Overly,
is-
oh, sorry.
Sorry, go ahead, Stephanie.
No, just to answer specifically for women's health, so what would be included in that category? It would be pregnancy and postpartum care could be covered under this. Menopause care, behavioral health specific to women's health, as well as Michelle had mentioned, lactation consultations.
Okay. Thank you. That answers the question. Thanks.
Are there any additional questions on this slide? Okay. So on our next slide, we wanted to talk through some additional details on utilization statistics as well as expected costs. So the data we're reflecting in this slide is intended to illustrate both ends of the spectrum here. So what that means is if the state were to adopt all three enhancements, the potential savings that could come from that. These are estimates that were provided by Highmark if the adoptions of these enhancements actually replace the in-person care. But we also wanted to show the potential costs. So that's primarily estimated by Willis Towers Watson if the adoption of these enhancements were to increase the utilization. So that's incremental to what the GHIP is already incurring through in-person care today. So you'll see at the top portion here that Highmark has provided an estimate of the net savings ranging from 0.3 million to 0.6 million annually. Again, this is if all three enhancements are implemented. And below this, you'll see the assumptions that have been made. So the actual utilization and savings for the state may be different and depend on factors that may change from year to year. This does assume that 3 to 5% of those visits migrate from in-person care to virtual setting. And the savings are not guaranteed. The savings estimate shifting from in-person to virtual has a lower, this will have a lower total cost than an in-person visit. However, that's, again, like I said, not necessarily guaranteed. And then we also, as you'll see at the bottom here, since the telehealth enhancement specialty areas are currently experiencing a shortage in the providers and, of course, like lengthy waiting times and getting a provider or an appointment, it could be now that if you allow these to be an option through telemedicine, that you start to see an increase in the utilization because they're now seeing there's an opportunity to see providers. So we wanted to make sure that showing the higher utilization could lead to additional costs. So the savings estimates vary by the numerous factors, which could be the service provided, the utilization, the member demographics, and with the utilization services estimated from Highmark, which were the 3 to 5, could change from the in-person to the virtual care. If you added those three services in, that could add 0.2 million to 0.3 million to the state's annual net cost. But just pointing out, this is prior to factoring in any of those savings. So we just wanted to make sure that it's clear, although we're seeing this estimate for savings, we want to make sure we're accounting for the possible cost as well. And the cost estimate includes the net claims costs to the plan. So that's the after the member cost sharing, and assumes that the state is already paying the 0.65 per employee per member administrative fee for the Well 360 program. Let me see here. I think that's
Hey,
everything
Michelle,
I have.
can I ask you a
Yeah.
question?
Sure.
So your last bullet point, is
Mhm.
that saying that we can add this and there won't be any net? Do we already pay the 65 cents per employee per month already?
Yes, the per employee per month administrative fee is the same as is currently being paid. I think the main difference that was shown on the previous slide is just that you now have additional claims cost based on the different visitation types. So if it's women's health or dermatology or primary care, those are currently not available. So the cost of those are different for some of the visit types in comparison to today. So the reason I'm saying some is the urgent care under women's health, although as I mentioned, they may not have the specialists today in the urgent care that they would for the virtual urgent care that they would for women's health. It's still the same cost for the urgent care piece under women's health, for example, but other items that were not listed are there. But 0.65 per employee per month is the same currently and with the new enhancements.
Michelle, it's Faith. Do we know if this were recommended for approval to the SEBC and implemented, do we have any sense of how Highmark would promote this or make Highmark members aware of the additional services available through the program?
That's a good question. I did not follow up with that specifically when going back and forth on this item, but I'm happy to take that one away and circle back with the subcommittee as well as the SBO.
Okay, thanks. I mean, it seems to me like a great opportunity. It's somewhat a targeted population, particularly with regards to the women's health. So, I mean, I see some opportunity to potentially collaborate with providers. Obviously, through claims data, we would know this population, and I think it just would be fairly easy to make them aware of the services. I mean, generally speaking, I think this makes sense. We do know that there is a shortage of providers, and seems to me that, you know, expanding access to this type of care for a population, you know, where we can make sense.
Yeah, and I think the dermatology as well, just given that there are also shortages there and understanding that, you know, employees that have Aetna can access that currently is also a good opportunity, was what we were thinking as well. Any other questions on the utilization statistics and expected costs?
This is Bert. I assume that when Highmark proposes these types of things, they've gone through like a medical review, and it's, you know, it's been deemed to be appropriate for telemedicine, and, you know, and an advantageous situation, right?
Yes, that's my understanding. And they provided us a lot of details on the information behind that as well. So if you have any additional questions, I'm happy to dive deeper into that level of detail.
I guess I was just more concerned about like the quality. You know, there's a whole range of services that are being offered. They pick these out as, I assume, because the science behind it makes sense too.
Yeah.
And Michelle, I'm sorry if you shared this with us, but what's the time frame if the committee were to approve this in terms of implementation?
If I have it in slide here, give me 1 second, please. I don't have that in my notes specifically. I'm going to write that down as a takeaway as well, Faith, and I'll circle back.
Okay, thank you.
You mean like implementation timeframe?
Yes.
Okay. I'm going to assume the 90 to 120 days, but I'm going to note it down to make sure we have the exact answer from Highmark.
Thank you.
No problem.
Any other questions from subcommittee members?
Faith, on the last page, it says subcommittee to make a recommendation. Are you looking for that today?
Well, there's a couple of follow-ups that we owe the subcommittee. So, I mean, certainly interested in thoughts if the committee's generally in support of this, but at this point, I think I want to circle back with some of these clarifications before we make an official decision on elevating to the committee, which we could do in October.
Okay. Fair enough.
Thanks. Great. I think that takes us to some updates on another topic that we've had some discussion around in recent months. I think the Willis Towers Watson team is gonna provide us some updates on a couple of follow-ups and takeaways specific to gene and cellular therapy.
Yes, I think that's me. Thanks, Faith. So good afternoon, everyone. Jacqueline Iglesias. So we had some conversation in the July subcommittee meeting about just some general updates and an overview on the gene and cell therapy landscape. There were a few questions from that discussion that our team has had an opportunity to go back and research and are bringing those answers to the subcommittee today. So we're going to go through specifically focusing on those questions, but certainly happy to offer any additional clarifications in case there are other questions as well. So again, as a brief refresher, since it's been a couple months since we've had a dialogue about this topic, there are several different programs available to the state today, and of those, some are already in place for the GHIP. And the goal with these is really to help mitigate the high cost associated with these types of gene and cell therapy programs, or I should say gene and cell therapy treatments and medications. And in addition, some of these programs also couple higher quality providers, higher quality processes alongside of the interventions associated with managing the costs. So we're not sacrificing the quality of care for a reduced rate on some of these therapies. So what we see in the marketplace generally is that most plan sponsors today are looking to their medical carriers and their PBMs to provide these types of programs and support for helping plan sponsors manage the cost of this care. And consistent with that, the state is doing the same thing today, having in place both the Aetna Institutes of Care for Gene-Based Cellular and Other Innovative Therapies, or the GCIT network that's in place today. And then similarly for Highmark, there is a Gene Plus Outcomes program that looks to monitor the efficacy of certain patients that have been taking these cell and gene therapies. It's a subset of the entirety of the therapies available on the market, but then seeking refunds from the drug manufacturers if these therapies don't deliver on expected outcomes. So again, we're trying to ensure that there's quality in the care that's delivered and that the care is meeting expectations, while at the same time managing the cost that the plan is paying for these types of therapies. There's another program in place, or I should say, there's another program offered through CVS Health directly that is not in place today. And it is essentially offering a financial protection plan, offering individual stop loss for the high cost of these therapies. And we'll talk a little bit more about stop loss in a few minutes, but I just want to make the point that this is an offering available today. It's not in place today. We are seeing most of the cell and gene therapy utilization come through the medical plan as opposed to PBMs. And that's a general commentary on the overall market in terms of what we're seeing. Currently for the state, there's no GHIP plan participants that have utilized any of these medications. So we're not seeing any current utilization today, but we also want to be proactive in ensuring that there's a plan in place for the management of the care and the quality and the cost associated with these types of medications, if at some point when a member may require them in the future. So I'll just pause here again. This is just meant to be a refresher on some of the things that we talked about from our last meeting. Are there any questions from subcommittee members at this point? Okay, hearing no questions, we'll move right into the first topic that we wanted to cover in more detail today. So we had a little bit of conversation at our last meeting where we talked about this in terms of whether the state should consider purchasing stop loss insurance to cover the potential financial liability associated with these types of treatments. So as I mentioned a moment ago, there are several different vendors out there that offer stop loss insurance that covers cell and gene therapies specifically. CVS is one of them, and that is probably the most direct opportunity for the state to consider based on your current vendor partners. From our point of view, and again, we're seeing this in the overall marketplace as well, we don't recommend that a plan sponsor considers purchasing stop loss insurance that specifically cover these types of therapies. And the reason being, while these therapies and medications are very high cost, they are fairly rarely utilized. We don't see a big uptick in the population, in a general population for these types of treatments. You're going to see a far less likelihood of somebody need a cell and gene therapy than you would, let's say, another type of high claimant. And in the example we provided on the slide, you're going to see, in theory, more likely having a fairly high, premature newborn claim, or a high case of another type of medical condition, typically before you're going to see utilization of a cell and gene therapy. Just the likelihood of one type of instance occurring versus another is a lot greater for some other types of more commonly seen diagnoses or clinical conditions that require treatment under the medical and pharmacy plans. As I mentioned a moment ago, today the state's plan has no members that are currently using these therapies. So something to consider, or at least keep in mind as we talk about stop loss. And then from our last conversation as well, we did also talk about the cost for stop loss products is fairly variable. When we look at the stop loss insurance that is offered specifically for cell and gene therapies, again, this is going to vary based on who the insurer is that's offering it. We typically see about $1 to $3 per member per month associated with these types of stop loss products specifically for cell and gene therapy. And if we were to apply that cost range to the state's population, we would estimate that if the state were to buy this type of stop loss coverage, again, specific to cell and gene therapies, you'd probably be looking at an annual cost of between $2 million and $5 million. That would be, that predictable cost that the state would pay regardless of utilization of this type of therapy, with the understanding that if this type of therapy or these types of therapies were utilized, there would be that financial protection in place from the stop loss insurance, again, kind of trading off that predictability of the premium rate that you'd be paying against the possible likelihood that someone might need the medication or this type of treatment, that is. So that's some considerations on stop loss, again, specific to cell and gene therapies. If we continue this thought around stop loss and broaden it to more generalized stop loss policies, which are much more common in the industry, for the state or any other plan sponsor that is considering purchasing stop loss, our point of view is that it really comes down to your risk philosophy with respect to this decision whether to purchase stop loss insurance in general as protection against high claimants of any type of condition or treatment need. As I alluded to, this type of coverage is really a trade-off between having a more predictable cost basis for what you're paying for the plan. Again, looking at kind of limiting the amount of high dollar claims at a certain stop loss threshold, with the trade-off of you're going to be spending some probably higher cost in premiums overall, simply because of this being an insured product. Based on our benchmark data looking at the costs that other large plan sponsors are paying for stop loss, and also looking at a range of typical stop loss deductibles that a larger organization might elect to cover or to have as part of that stop loss insurance policy. We're anticipating that the state could probably look at paying anywhere between $5 million and $13 million or more for this type of coverage. Again, that range is really based on the deductible of the stop loss insurance itself. So specifically, you can have a stop loss policy that sort of caps plan sponsors financial liability at a certain amount. And the range that we've picked here is between $750,000 and $1.5 million. So if a claim came in at $2 million and you had $1.5 million in stop loss coverage, you would have the claim capped at $1.5 million for your financial liability as a result of having that stop loss coverage, in addition to then also paying premiums on that stop loss policy. The last bullet really just speaks to the fact that there would be some potential for that cost of the stop loss premiums to be offset by reimbursements for claims above the stop loss deductible. So back to my example, if you have a $2 million claim and a $1.5 million stop loss policy, that difference of about $500,000 would be essentially that reimbursement that the stop loss policy would pay back to the plan. But in cases like these where we're talking about such high dollar thresholds for stop loss deductibles, the likelihood of those reimbursements are probably not going to be large or frequent at this point in time. So that's quite a bit of thoughts on stop loss. Certainly happy to take questions or provide clarity if there's any need to do so from subcommittee members.
Jacqueline, this is Bert. I'm sorry.
Hi, Bert.
So usually when a state purchases insurance for other things, it's for one-time things that are in nature. You know, you have a building, a damage to a building or something. Are these types of claims, are these ongoing claims? If somebody's on this type of therapy, are they on it for a number of years? I'm not sure. Or is it a one-time claim or what?
Yeah, Bert, that's a great question. Typically, for most types of cell and gene therapies, it's usually a single dose administration, sometimes two in some cases. It really depends on the type of cell and gene therapy and the specific condition it's aiming to treat. But we typically don't see people on these on a long-term ongoing basis.
Okay, thank you.
Jacqueline and Steve, that $5 to $13 million estimated range provided by WTW, is that based on what you're seeing similarly sized plans to pay for stop loss? Just general stop loss coverage, not specific to cellular and gene therapy?
That is correct. That range is for general stop loss across all types of conditions, all types of treatments. There is, of course, likely policy language on certain types of exclusions, but by and large, this is across the board and not specific to just cell and gene therapies. And yes, it is based on a similarly sized employers compared to the state at a range of those stop loss deductible threshold amounts.
Okay.
Any other questions or comments from the subcommittee? Okay. So I think as a natural segue from our introductory conversation about stop loss, there was another question from our meeting last time related to some market data that we had shared about the types of organizations that do elect to buy stop loss coverage for cell and gene therapies specifically. And the data point that we had shared last time was between 17% and 29% of organizations that had responded to some of our market research surveys during the last 12 to 18 months. And during the discussion last time, there was a request for some additional information about the organizations that have indicated that they've purchased stop loss. Either what can we learn about the organizations themselves or about the demographics of the employees that are associated with these organizations that have this type of coverage. So for a little bit more context about the organizations behind these numbers. So this information came from WTW's 2023 best practices in healthcare survey. And this includes responses from over 450 organizations across the suite of industries in the general market with at least 100 or more employees. And when we looked closer into the specific organizations that are captured in the original statistic we shared, they appear to be relatively evenly distributed across a variety of industries, across a variety of employer sizes, and finally across a variety of different for-profit or not-for-profit, employer statuses. So we've included some statistics here that sort of represent, if we had to say, one type of industry or one size or range of size of an employer kind of bubbled to the top, what we found is that the most frequently represented industry in the data, again, of the 17 to 29% of organizations that have this insurance, manufacturing was the top industry with about a quarter of those employers included. We did tend to see organizations that have between 1,000 and 4,999 employees as the most common employer size, so certainly significantly smaller than the state of Delaware as an employer. And then finally, for-profit publicly traded organizations were the most common profit status that were captured in the data. And looking at the composition of the overall series of employers that responded to the survey as a whole, these results do pretty closely track the proportion of employers that reflect and that responded to the overall survey itself. So we're seeing the subset of employers that indicated they do have stop loss coverage for cell and gene therapies looks a lot like what we would typically see overall in terms of, kind of a broad set of employers across the marketplace. In terms of the employees reflected by the employers that responded affirmatively, we don't track that level of detail in the survey information collected to really be able to provide further insight into how the employee demographics associated with these particular types of employers may be similar to or different from the state group health plan demographics. So unfortunately, we're not able to provide any more insight into what their employee populations look like, but hopefully this helps address the previous question just around what are we seeing in terms of other employers that do tend to purchase stop loss for cell and gene therapies. So then moving on to how other employers or how other payers may be paying for these types of cell and gene therapies, and what are other either alternative payment models or alternative contracting arrangements available in the market. And we do have some further insight to share on this today. This is, as much as cell and gene therapies are an emerging area of the marketplace, the payment structures associated with these types of therapies are also continuously evolving in the market. So while there are instances or examples out there about other alternative payment models and contracting arrangements, these have not yet been widely adopted by other plan sponsors in particular. And some of these do have some relatively limited availability for a self-insured plan sponsor like the state of Delaware. Of course, we'll continue to keep the state apprised as new developments occur and will likely continue to play out as additional cell and gene therapies are approved and come onto the market. But at this point in time, what we are seeing most employer plan sponsors do is to continue to work directly with their medical carriers and PBMs to support the management of the cost and the quality associated with delivery of these types of therapies. So diving in just a little bit further into the chart. So one alternative payment model that we're seeing is the availability of amortized loan products, which essentially amortizes the cost of a cell and gene therapy over multiple years as a loan that travels with the member, so from one payer to another. And potentially can be offset by quality warranties that the manufacturer, the drug manufacturer, is willing to provide about the efficacy of the cell or gene therapy itself. Again, this is probably the least. This example is probably the least tested in the market yet. We're not aware of any employers that are using this. Based on some of the description, it appears to be more geared between drug manufacturers and fully insured health plans. But there are some, and I think that largely is due to some considerations associated with this type of payment model, including kind of the ability for this payment structure to kind of travel with the member, even if they change their plan. So again, there's a lot of open questions about how this could potentially work, including from a compliance perspective, if there is even an ability for payers to, kind of carry that payment for prior services from one employer to the next. But this is an emerging model. Again, it's relatively new to the market. And it is something that at least one financial entity is advertising as a capability. The next item in the chart, an installment payment plan. This is a little bit more, I think, tangible to a plan sponsor. And this is really where some of the carriers and PBMs are allowing the ability to basically create a payment plan associated with a cell and gene therapy over multiple years. The key difference between this item and the prior one that we just talked about is that the payer or the plan sponsor is still responsible for the entire cost of the cell and gene therapy. It's just they get to spread that cost out over multiple years. And even if the member who needs the therapy changes employers or changes plan options, the original plan sponsor that they were with when they had the need and incurred the claim for the cell and gene therapy, that's still the responsibility for payment of the full amount still resides with that plan sponsor or payer. One example that is advertised in the market is, an opportunity through the CVS specialty pharmacy for a subset of gene therapy products could potentially be eligible for this installment payment plan. But again, this is another option or another alternative payment model that's out in the market. And then the last item in the chart here is around value-based contracting, where drug manufacturers agree to vouch for the efficacy and the results achieved through a particular cell and gene therapy, and it involves monitoring the clinical outcomes associated with the patient taking the therapy over a period of time. And if the outcomes expected are not achieved, then there's potential for some refunds that the drug manufacturer may pay as a result of this outcome-based agreement. This may or may not be available if the therapy is purchased through certain distributors. For instance, a self-insured PBM arrangement may be less likely to have this type of warranty. We are aware that CMS, their innovation center, is testing an outcomes-based arrangement approach for Medicaid. And there's currently some negotiation between CMS and the drug manufacturers that choose to participate with the initial cell and gene therapy indication really focused on sickle cell treatments as sort of the pilot case for this type of outcome-based arrangement. And coming up in January 2025, individual state Medicaid agencies can choose to enter into agreements based on CMS's negotiations around sickle cell and gene therapy treatments. So again, still very much an emerging area of the market, more focused on warranties between the drug manufacturer and the payer or the drug benefits manager. But again, in the spirit of wanting to talk about all that is out there in the market, these are a few of the examples that we're seeing in terms of alternative payment models. So just to wrap us up in terms of next steps, certainly welcome feedback and input from committee members. If there's any further desire to consider potentially whether to recommend the committee consider further evaluating any of these, additional cost management options for cell and gene therapies specific to the GHIP. I think a couple of the ones that we talked about are more focused on the drug manufacturers and the PBMs, but still I think there's a question of stop loss in either broad sense or limited to cell and gene therapies that the subcommittee can certainly consider and debate on. And then also, of course, as a next step, our team and the SBO will continue to monitor this item on an annual basis and certainly would report any significant changes in this space in the market to the subcommittees and SEBC.
Hey, Jacqueline. Can you hear me?
Yes.
Hey, just a couple of extra points around all this from a budgeting and pricing standpoint. Stop loss is insurance, right? So insurance carriers are there to make money. So over the long run, forget about annual volatility from year to year. Over the long run, it would cost the GHIP more, right? Whether it's to do just cell and gene therapy or more broadly, blanket stop loss at any level, it will ultimately cost the GHIP more. And don't forget that we now have in the rate setting for the GHIP, we have that component relative to the claim volatility reserve. And when it's built to the right level, that's there to protect us from the annual fluctuations from year to year of experience worse than we might expect. So I almost view it as that claim volatility reserve is likened to the GHIP self-funding its stop loss in a way, right? So at your size, it's not necessarily something that I think should be recommended because of those two facts, meaning again, the reserve that we have built in plus the fact that the insurance will ultimately cost the GHIP more over the long run.
Brian, you just said exactly what I was going to say. So,
Awesome.
but much more eloquently.
Oh, thanks.
Yeah, Brian, thanks for those comments. I mean, I agree. Unless subcommittee members have other thoughts or suggestions at this point, I appreciate the WTW team addressing our additional questions. I don't believe I have any additional questions at this time, nor am I inclined to suggest that we elevate any discussion to the SEBC on this topic.
I would agree, Faith. This is Bert.
Thanks.
Yeah, I would agree as well. This is Colleen.
Thank you, Treasurer. You're welcome. All right. I think that then takes us to other business. Do we have any other business that we would want to bring forth for discussion today? And then we'll move to public comment. Carol, do we have anyone pre-registered?
I do not have anyone pre-registered. Is there anyone that's logged in virtually? I see Steve on the page. Whenever you're ready, Mr. LePage.
Okay, can you hear me?
I can hear you.
All right, great, thank you. This is going to be hard to do in 3 minutes, but there are a couple times where HR 32 was mentioned, and there is a little bit of secrecy and lack of transparency going around HR 32. I had to kind of piece it together through interviews that were done with Representative Ramon and Helofsky, what they were alluding to in HR 32, and then materials on the SEBC that I found that kind of connected everything together. And what they were basically talking about is genetic testing. So they're talking about having state employees go and get their blood work done and then have their DNA mapped. So that is fine and dandy because there are some benefits to it, and I'll agree to that. But there are also some pitfalls to it. And I don't want to get into a situation like we had with Medicare Advantage, where the one side of the story was being touted, well, this is the greatest thing since sliced bread, and not talking about the other side of the issue. So there is a problem with doing genetic testing and mapping person's DNA, and they all around privacy, ethical, and legal considerations. So privacy concerns are obviously data breaches and unauthorized use of your DNA. Discrimination is, they could say, well, you're in a high risk pool because of your genetic data, therefore your insurance rates are going to go up, whether it's health insurance, whether it's life insurance, whether it's car insurance, doesn't matter, because insurance companies could have access to that data. Employment concerns, there could be impact on family members, revealing family secrets, implications for relatives, potential legal issues for forensic use by law enforcement. Legal changes in the future could alter the genetic data and how it's used. Data permanence. I mean, once you sign away your DNA, you can't get it back. Misinterpretation of results. And we've seen this throughout with some celebrities also, where they say, oh, you're at high risk for cancer of your uterus. And next thing you know, they have an operation to remove the uterus and they can't have children. Or maybe they're at high risk for breast cancer and they remove their breasts. It provides an incomplete picture a lot of times. Commercial exploitation of your DNA, obviously ethical concerns. The other thing is that I didn't have listed down here was military use, which I'm prior military, and that's a gold mine of data, whether you're a friend or a foe. So I want to make sure people are aware of these issues as well.
Is there anyone else that would like to make a public comment today? I don't see any other hands raised.
I think that takes us to adjournment. Anyone like to make a motion to adjourn?
This is Bert. I'll move to adjourn.
Thank you, Bert. Do you have a second?
This is Courtney, I'll second.
Thank you, Courtney. All right. Thank you, everyone, for joining us at SEBC next Monday, 2 p.m. Enjoy the rest of your Monday. Thank you.
Thank you.
Bye.